Hello again to week 4. The previous sections have highlighted the process of genetic counselling and testing. We have shown the role of cancer clinicians in incorporating genetic counselling and testing into their clinical work to ensure that the patients have access to genetic testing and treatments. The clinical geneticist in genetic testing and counselling remains critical in ensuring the care of the patients and family members is not compromised. This week, we are going to look into the concepts of risk management, the important concepts of genetic risk predisposition, which is the cancer penetrance and risk thresholds in affected and unaffected individuals. This week, we are going to understand the different risk formats and how to communicate them effectively to the clients or patients. Framing susceptibility by comparing carrier risk to baseline or average population risk remain important in helping patients make decisions on genetic testing and counselling. People are most likely to take preventive actions if they perceive a threat. The health belief model and more recent iterations state that health-related behaviours depend on a combination of several factors. Firstly, perceived susceptibility to cancer. Number 2, perceived severity of the cancers. Number 3, perceived benefits of the strategies that they are doing for risk reduction. Other modifying factors could include psychological makeup as well as coping mechanisms of the patients, their social support, social pressures, and normalization of risk management, and their self-efficacy. The average population risk in your practice will help contextualize the risk that the patient has in relation to average population risk. In Malaysia, the lifetime population risk for breast cancer is 1 in 19 or 5%. Ovarian cancer is 1 in 167 or 0.6%. Prostate cancer is 1 in 94 or 1.1%. And the last one, pancreatic cancer, the risk is actually quite small. It is now the 13th and the 17th cause of cancer among men and women respectively. Therefore, the lifetime risk is very low. This slide really looks at the comparison of incidence of breast cancer around the world. You can see that Malaysia has a fairly low to moderate risk of breast cancer compared to North America and Australia. So we know there are several risk factors that are non-modifiable and modifiable, and of course, genetic risk and genetic predisposition are non-modifiable risk factors. In order to assess risks, there are mathematical models that have been used, but however not found to be suitable in our local population. In women of European descent, a number of risk assessment tools like the Bohdisier, Gale, Tyrer-Cuzick risk models have been built using predominantly lifestyle factors and family history of cancers in order to estimate an individual woman's risk of breast cancer. The NICE recommendations for unaffected women aged 35 years and older and with no physical symptoms of breast cancer may be stratified into 4 categories using this Bohdisier risk assessment tool for the purpose of screening recommendations. Average risk is defined as people with less than 17% lifetime risk. Moderate risk is between 17 to 30% lifetime risk. High risk is more than 30% lifetime risk. And for very high-risk carriers with more than 40% lifetime risk, these are usually seen in people with pathogenic and likely pathogenic variants of the BRCA genes and other genes. In a local health technology assessment of various risk assessment tools, the Gale model was shown to have good calibration and moderate discriminative ability. However, it was not suitable to be introduced as one of the strategies in the prevention of breast cancer under the Malaysian National Cancer Control Program, as it needs further validation to become a more well-fitted model. Let's look into risk thresholds. The risk thresholds given by the National Institute of Health and Care Excellence guidelines in the UK context puts a threefold increased risk defined as high risk. Therefore, 30% threshold is given when the lifetime average population risk is about 10%. Thus, 30% in the NICE guidelines is defined as high risk, and more than 40% is categorized as very high risk. Most studies are done in European countries where breast cancer incidence is higher, about 10%. Thus, the relative risk from European studies will be relative to this background risk. Given the low population risk in Malaysia of about 5%, we will refer more to the absolute risk of having the BRCA pathogenic and likely pathogenic variants. Let's look at the level of penetrance in known breast cancer susceptibility genes. So in the very high and high risk group, which is 10 to 20-fold relative risk, the genes are BRCA1 and 2, TP53, and the PALB2 genes. Intermediate risk would be CHEK2, ATM, CDH1, PTEN, or the BRIP genes. Possible low risk or less than 2-fold would be the FANCA genes. Let's look at the genes in which breast cancer risk has been established. So we can see these are the common breast cancer susceptibility genes, and you can see that the absolute risk, some are more than 40%, like BRCA1, 2, TP53, CDH1, and PALB2, putting these genes as categorized as very high risk. So cancer penetrance refers to the proportion of people with a particular genetic variant who develop cancer. BRCA is a cancer predisposition gene that does not confer complete penetrance. Therefore, not all BRCA carriers will develop cancer in their lifetime. So, the causes of incomplete penetrance include the type of mutation and other epigenetic modification, the environment, the age of the patient, the gender of the patients. Okay, the first gene is BRCA1 of the hereditary breast, ovarian, pancreas, and cancer syndrome. The type of associated cancers include the first primary breast cancer, which is usually triple negative, medullary subtype, and they usually occur in the 3rd to 4th decade. The absolute risk by age 70 ranges between 57 to 65%, and you can see the difference between population risk in the US, in the UK, and in Malaysia. Therefore, this is a 10-fold increase in risk. For contralateral breast cancers, is actually higher than the general population, where we quote it as 3% per year or up to 30% at 10 years, which persists up to 30 years. So in Malaysia, the second cancer or contralateral breast cancer is about 2.8% in 10 years. So also again, you can see the marked increase compared to the patients without the BRCA mutation. For ovarian cancer, the absolute risk by age 70 is about 40%, and you can compare that with the population risk of about 0.6%. And for male breast cancers, the risk in the population is negligible, but for BRCA1 is between 0.2 to 1.2%. For prostate cancer is 7 to 26% compared to 1.1% in our population. For pancreatic cancer again, even though the penetrance is 5% and below, but you can see that in Malaysia, the population risk is actually very, very negligible. So for other cancers like gallbladder, stomach and colon, there is a slight increase compared to the general population. For the BRCA2 mutation, you can see that for the primary breast cancer, the absolute risk is 45 to 49% by age 70. And you can see that in the different countries, again, this is at least a 10-fold increase in risk. For contralateral breast cancer, again, the risk is higher in BRCA2. For ovarian cancer, you can see the difference again. It's slightly lower than BRCA, penetrance. For prostate cancer, it is definitely higher than the BRCA1 penetrance, with a 19 to 61% risk by age 70. For prostate cancer in BRCA2, they are likely to be higher in the stage at diagnosis. They are more aggressive and in younger patients. So for male breast cancer, again, the risk is between 1.8 to 7.1%, which is considered significant. For pancreatic cancer, it's between 5 to 10%. There have been concerns about the penetrance in Asian populations, as most of the previous research were in the European populations. But for the 12 genes that had evidence of an association with breast cancer, the effect actually did not differ between European women and Asian women. So we can say that we can quote figures from this paper to our patients in our population. So how do we frame individual susceptibility? Whenever we speak of numbers, patients may become more confused. Therefore, we should use pictures or cartoons to help patients understand their risk. When we want to compare someone in the general population and the one with the BRCA1 mutation and BRCA2 mutation, the patient can appreciate the increased risk compared to what you see in the 5 little women figurine here. For ovarian cancer risk, you can see again the lifetime risk in the people who do not have the gene is less than 2%, but when you compare it with BRCA1 and BRCA2 individuals, the risk is very high. If the patients who have had cancer, understanding their future cancer risk would require them to understand what is the risk of their contralateral breast. So here in the blue section, we have information for people who have had cancer. So in order for them to understand that their risk for BRCA1 and BRCA2 carriers are increased compared to average Malaysian women without the genetic change. So the risk in our figure here shows that for people at 10 years after the diagnosis, 2.8% in people who do not have the genetic risk, compared to 23% in people with BRCA1 and 16% in BRCA2. So the increase is more than tenfold for BRCA1 and about 5 times more in the BRCA2 population. There are risk assessment tools like the breast and ovarian analysis of disease incidence and carrier estimation algorithm or BODCA model that provides breast and ovarian cancer risk estimates based on the UK breast cancer incidence. Risk factors such as age, family history, mammographic density, polygenic risk scores, reproductive, hormonal and lifestyle information can be imputed, and you will be able to give individualized estimations to your patient. You can access this calculator, but caution that it is used based on the UK cancer incidence and may not be applicable to your population. This highly comprehensive model would enable high level of risk stratification to individualize prevention, therapies and screenings. Recently, the polygenic risk score may be able to identify women at low risk of breast cancer that may not even need screening. So what is the risk in BRCA negative individuals? So about 20 to 30% of breast cancer patients have a significant family history. A woman's risk for breast cancer is higher if she has a mother, sister or daughter, or this is first degree relatives, or multiple family members on either her mother's or father's side of the family who have had breast or ovarian cancer. Having a first-degree male relative with breast cancer also raises a woman's risk. Studies have shown that the relative risk of cancer risk between those with significant family history compared to the general population. The relative risk of this study or the generation study shows that the number of relatives as well as the type of relatives, that means combination of relatives, and the young age of the relative at diagnosis makes the patient at a higher risk of breast cancer. Therefore, the best model for determining breast cancer risk due to family history was combining the family history and the age of the relative at diagnosis. Women who have had 2 or more relatives with breast cancer, the strongest conventional familial risk factor, had a 2.5-fold increase in cancer. Individuals with strong family history of cancer but with no pathogenic or likely pathogenic variants or whom do not undergo genetic testing may benefit from further risk assessment using calibrated tools such as Boadicea and offered screening according to their estimated lifetime risk of cancer. The CanRisk tool is a web interface to Boadicea and can be accessed. The breast cancer risk assessment tool or the online calculator based on the Gale model also allows health professionals to estimate a woman's risk of developing invasive breast cancer over the next 5 years and up to the age of 90. The tool uses a woman's personal medical and reproductive history and the history of breast cancer among her first-degree relatives to estimate absolute breast cancer risk or her chance of or probability of developing invasive breast cancer in a defined age interval. In conclusion, the penetrance of BRCA1 and 2 pathogenic and likely pathogenic variants is not 100%. However, carriers are stratified as high risk. Making comparisons with average population risk will help frame the high predisposition risk to the carriers. We may have to discuss with patients using lifetime risk rather than risk at every decade if the data is not available in your population. The next section will delve into the evidence-based risk management of BRCA carriers.